All right. Hello, everyone. This is Howard Mann stepping in for Jeff Caney this week. Welcome. Travis is going to start us off this week. Go ahead, Travis.
All right. So you should see this radiograph here. This is
Good.
a middle-aged patient who has multiple comorbidities. I believe they're an intravenous drug user. Came in, and you can see there's this retrocardiac opacity. I think there's some other busyness here too, but you'll see that there's a lot of consolidation. You've lost the left hemidiaphragm, and then there's some areas that look a little bit more loosened in that region. And the CT that they underwent, you can see that, in this consolidation, there's a lot of necrosis, and this doesn't look like it's a pulmonary artery infarct. It looks more like a necrotizing pneumonia. And this patient did grow some bug, and I can't remember because it's been a couple months. But this was the study that they had. They were on antibiotics, and then came back 10 days later and had this CT, and you can see that they've got more stuff going on in their lungs. I think they had a little bit of edema in addition to what's going on down here. And now you can see that there's this new high attenuation, and it's very circumscribed within this area of necrosis in this necrotizing pneumonia. And so they had hemoptysis at this time, and the thought was that this was some sort of pseudoaneurysm or mycotic pseudoaneurysm in the setting of infection, except it's pretty large. And there was some question, people looking at it like, wow, I've never seen one quite that big, but that made the most sense. And so they went to angiography to look for this. And in this case, it was hard to tell for, now I thought this was probably coming off of a pulmonary artery branch. And I don't remember, I think we had thicker slices where you could kind of see a little branch in here. Let me thicken this up just a little to see. Yeah, it's kind of hard to tell where it was coming off of. But anyway, the IR folks started with a aortogram looking at bronchial arteries, and no luck, didn't see anything, and looking at intercostal arteries as well. So this was not coming off of a systemic vessel. And then they moved to the pulmonary artery, and you'll see that in fact, here they were a little too distal when they did this pulmonary arteriogram, and then they backed up their catheter a little bit, and let's see, it's not that one, maybe this one. And there you can see, it's actually when it refluxes into the other branch, you can see this huge pseudoaneurysm that's arising from a pulmonary artery. So it's not TB. So for those that like eponyms, I mean, technically it's not a Rasmussen aneurysm, I guess, but it is a mycotic pseudoaneurysm. And they did eventually, they did embolize this thing. And she was still having hemoptysis after the fact. And so they repeated the scan a couple of days later, and you can see the little vascular plug they put in that pulmonary artery branch. I think it was important that they got this non-contrast study because you can see all the contrast that's still pooled within that pseudoaneurysm. Because if you'd only done post-contrast at this point, it looks the same, but you might have thought there's still filling of that pseudoaneurysm. But I think this is the largest PA pseudoaneurysm I'd seen in the setting of infection, and kind of that was the consensus here.
So
And I don't.
Terminology, Travis, do you think that there's disruption of a pulmonary artery at some point, but then the contrast medium fills a large space in the lung parenchyma itself, right?
Yeah, I mean, yeah, and again, I think this is where the terminology fails us, right? There's been some disruption to a pulmonary artery branch, and you've got this pooling of blood that's kind of contained, but not fully contained. Yeah, I don't know if this is within lung, or if this is if you've still got a little bit of adventitia of a vessel that's just ballooned out. I mean, it does look pretty. It looks pretty circumscribed on that.
And large.
This, yeah. I mean, but it is really large. I don't know.
Yeah.
What would you call it? I guess I'm curious because I just.
I'm
Yeah.
thinking there's a large pulmonary space that's filled with the extravasated contrast medium? And is it particularly large because there was a space already there from the necrotizing pneumonia and the blood is just filling a pulmonary space, an area of cavitation or equivalent in the lung itself?
Yeah, I don't know. I mean, you wonder.
You know,
I wonder
technically,
because
I mean, it would still theoretically be a pseudoaneurysm because
right,
it's a rupture. I mean, it's basically a contained rupture, which still falls in the criteria of a pseudoaneurysm, but
right.
it may be contained within a necrotic lung.
Okay, yeah.
Yeah, I
Yeah.
guess.
But I see what you're saying. Is it blood pouring out into an empty necrotic hole,
Yeah.
or does it actually have some vessel around it, like
Yeah.
some
Yeah,
wall of a vessel?
right.
And
It's got some sort of wall around it. Whatever that's made up of, I don't know, because it's too regular to be. It's got a smooth margin. It's not like you've got other areas of necrosis surrounding this that aren't filling with contrast and blood. So, but yeah, I mean, I
Yeah,
think some of it is
sure.
semantics. The big question was whether it was arising from a pulmonary artery
Yes.
or a bronchial artery
Yeah.
or systemic artery. And in this case, it was pulmonary artery.
Yeah.
And so with that, I'll show this case, which came in a week later. And this is a patient who has had disease for more than a couple of weeks. They've got severe chronic underlying lung disease. They have an underlying autoimmune disease, and they have underlying fibrosis, and then they've had chronic infections for years. And it's really, it's the lung disease itself is difficult to classify, I think, but they did have a mycetoma in one of these spaces in the right upper lobe, and then came in with hemoptysis. So this was, literally 2 days after that other patient, and I saw that one, and now you have a nice little contained space or contained pooling of contrast in the right lung within one of these cavities. And so this one, especially armed with the knowledge of the other one arising from the pulmonary artery, you can see that this one looks like it's coming from this pulmonary arterial branch. So we thought this was going to be another pulmonary artery pseudoaneurysm. And in this case, they did the PA angiogram first, and there was no filling. And then they did a aortogram, and lo and behold, now you see the filling is from one of these chronically dilated intercostal arteries. So this was actually a systemic artery pseudoaneurysm in the setting of infection in the lung. And I talked to the interventionalist because we were both kind of surprised. I mean, because I still think, we looked at it, he agreed, he thought that this little vessel right here, we thought was going to be the feeder from the pulmonary artery kind of right in here. And then it was more, it's hard to tell. I think partly it probably is from right here wrapping around into this network, maybe, of systemic arteries. But, we're a little bit earlier on our phase of contrast, and it was, tough to ever see it. But, so it was filling from a rich network of collaterals from an intercostal in the setting of chronic inflammation.
Wow, that's impressive.
Yeah, so 2 within a week, one from the pulmonary artery and one from the aorta. David's not on, is he? Because I had pulled up this case when I was last on in December. He
No.
showed a case of this in an adult. I'm going to show a case we had in a kid, and you'll see this is a kid who had a cough, and I don't know what else. But you can see the difference between these two is this right here, which is this big apical lung hernia. And it wasn't present on the prior. And you can see that it does cause mass effect on the trachea and displaces the trachea leftward. And it's a portion of the right lung. So David had shown a case of an apical lung hernia. They went to evaluate this with CT, and you'll see on the CT that, lo and behold, it is not there on the CT. But, you know, much like I think we've shown cases of dynamic chest wall hernias, especially in patients that have had thoracotomies or other surgery where they have laxity of the chest wall or dehiscence, there's this weird, presumably just a little bit of fibrosis and remodeling in that apical lung, because the hernia is not just gone. And as David talked about, there's the fascia at the apex of the lung, Simpson's fascia, which for whatever reason can be weak. And so they went to fluoro, and I'll just go through the fluoro. And I don't know if they were just having the child breathe or have him try to cough, but you can see between here and when he inspires, and actually, no, it's actually when he exhales, you can see the ribs getting closer together, that you can see this dynamic hernia
Oh my
through
word.
the lung apex.
So was
So
the
there it
pleura
is, right there.
was the pleura normal on the CT? I mean, that's so
Yeah, I'll
weird.
go back to it in a second, but isn't that cool? Just the dynamic
Yeah, I
nature
mean,
of that
that's
lung hernia.
freaking weird.
Yeah, that's very dramatic.
Yeah, I'll show the coronal here. Yeah, you can't really see. I mean, it looks totally normal. I mean, I don't see anything,
Yeah, that's really weird.
but you can. I mean, this has got to be just some chronic remodeling of that lung and just a little
Yeah,
bit of
scar from just
scar
going up
from
and
the
down.
dynamic hernia. Yeah, so I think this was an incidentaloma in this kid. They're going to watch it. They haven't done anything yet. But yeah, so this had been shown, you know, I'd seen this from one of our residents like a year ago, and when David showed that case, it reminded me to go digging for it. So it looks like this kid probably had some sort of bronchiolitis unrelated, which is probably why he had the cough and got the radiograph and got this whole workup in the first place. So
Wow, I've never seen one of those before. So is it a known thing? Transapical herniation lung pediatric radiology? Odd.
yeah, let me actually, I'm gonna pull up the paper. I stopped sharing for a moment, and here I'm gonna share this. And oh, look at that. Charlie's on there too with Paige. They talked about apical lung hernias. This was not in pediatric patients. This
Oh,
was,
that's right. That's the one that David showed. Yeah.
yeah, this is the one that David showed. And this is an adult. I mean, I asked Paige, these cases are ancient. This is from well, not ancient, but long before the days of PACS. So he doesn't have any images of these anymore. But yeah, it's the weakening of this Simpson's fascia. And there's the herniated lung.
Very curious. Wow, pediatric one. I don't
So
recall having seen one before.
I've never seen one.
No. Very strange.
So all right, I'll stop there.
Excellent. Wow. Okay. Thank you.
I can go if you want. I think I've anonymized my cases.
Okay.
Let's see here. Sorry, let me shut down my pack so I don't show anything. Here. Nope, that's the wrong one. Oh, I just moved this over.
Okay.
So this is an odd case. So this is a woman from the Middle East, and most of this imaging is from the Middle East, who presented with a shortness of breath and had a large, apparently loculated pleural effusion there on the right. Not all the CTs anonymized? Shoot. Well, anyways, it didn't really change that much. She had a CT soon after that in 2000. Well, it did change. That showed really a tubular PE that looked more acute than this, but very kind of sausage shaped, but there's contraction of the lung distal or the pulmonary arteries distal tube, which you can actually see in sarcoma. But if I showed you the prior, you would see that this thing was actually contracting down. And then she had this very large loculated pleural effusion. Not sure how that's related or if it's related at all. She then, this is now many years later, and she also has some bleed. So the effusion may be related. She has some very strange bleeding disorder that required a lot of, that I didn't really understand, but involved a lot of preoperative uh, kind of integration between the hematologists and the surgeons. There's one I never heard of. It's a very rare blood disorder, but you can see this is now many years later, and that right PA is completely occluded with this chronic clot that's now increasingly calcified, still has this loculated effusion. So the idea was to, the concern was, A, if you're going to take out, so here's the most recent study, if you're going to take out that pulmonary embolus, here she was off of anticoagulation, you can actually see the clot kind of growing a little bit centrally. And the concern was, well, even if we open up that, and there is maybe a few webs on the other side, so not completely unilateral, but, and here's a little bit of disease down here, but the concern was, even if we take out this clot here, is it going to do any good with this large effusion compressing most of the lung? So anyways, they did their endarterectomy and got a, where'd it go? Hold on 1 second. And got a, nice result. But as part of the endarterectomy, they also did a decortication. So they did a large decortication, got out this very thickened rind of pleura. And you can see here's the specimen from the right with nice tails. And then here's the more distal stuff from the left lower lobe. She's doing better, but unfortunately she had her most recent x-ray, which I had read the other day. Unfortunately, that decortication didn't do the trick, and she's kind of reaccumulated that loculated right hydropneumothorax. So we'll see, they haven't done a repeat CT on her to see if that pulmonary artery she's doing better clinically, but to see if that's going to clot off again or stay open. Anyways, that was kind of a interesting.
It's odd in that it involves just substantially that portion of the right pulmonary artery, just in the right upper right, which is
It was the whole right. It was the whole right. It was the whole right lung. It was the whole here. Again, I don't have the original one shows it nicer, but it's sitting. It's the whole. You can see here. Here's the interlobar, which is gone. So it's the whole right lower lobe is out too.
Okay.
And it's just a big clot sitting in the right main, but all the basically lobar vessels are out.
Okay.
This is a case that was just sent to me of something. Hopefully there's a belly in here or chest in here somewhere. Well, I can just show it on the chrome. This is a person who had a resection for a tumor a couple of years ago, I guess, and it had locally recurred. Haven't seen one of these in a few years, but I think most of us would see this very abnormal fat attenuating mass in the anterior mediastinum, kind of draping over the heart with complex septations and all that stuff. And this was or is a mediastinal liposarcoma. So, most of the liposarcs we see, and I'm sure everyone sees, are the abdominal liposarcs, the retroperitoneal ones. But this is a nice example of a anterior mediastinal liposarcoma. So there's that case.
Yeah.
I don't know what happened. I downloaded another case. What happened to it? I screwed up. I was doing these so quickly, I think I might have screwed up. This is a case I had yesterday. And it's not, as this thing slowly loads, it's, I think, something we've all seen many times. I just don't think I've seen this sort of feeding of this before. So here's a guy who has a, I think most of us can see, oops. there's a fistula here. There is, let's see, there's a shooting vessel sitting next to the pulmonary artery that's dumping contrast in the pulmonary artery. You can kind of see it squirting, kind of going back and forth and squirting here. Let me do this, MINIP. Sorry, MIP. And you can all of a sudden see all this kind of bright contrast pouring into the main PA. So they thought that some of it may be coming from a coronary, but they couldn't really tell where it was. So they recommended getting a CT angiography of the aorta. And sure enough, there is some feeding of this fistula from the left main. There's this vessel here that then goes into this tortuous mix of vasculature that then wraps around the PA. But this was also being fed by, I don't even know what vessel this would technically be. I mean, I usually think of bronchioles arising from the inferior aspect of the aorta. There's this vessel that's coming from the superior aspect of the aorta that feeds this very complex tangle of vessels sitting above the main PA. And, you know, no one wants to spend the time going through all of these, but eventually they will connect with this fistula. And additionally, there is a bronchiole here that does supply vasculature that also feeds this fistula through this kind of tangle of, you know, better call it just a vascular malformation in some way. So, yeah, it's just a PA fistula. Usually these are all coronary to PA fistulas. I mean, that's the vast majority. And this is a very common location where they dump into. I don't, you know, we see these now all the time. Most of them are very small, and there's such a limited amount of shunt volume. They may treat them or may not. I mean, I think they treat them on the PA side and try to coil embolize this. I'm not sure what they're going to do with this one, but this is the first one I've seen that clearly had feeding off of coronaries plus two other systemic vessels. And then I don't know what I do with
very interesting.
Yeah, I don't know what I do with what happened to my last case. It's really I had another case, but I'll see if I can what happened when I anonymized it. But I guess that's all I have for right now. Maybe if I can find the last case, I'll come back and show it if there's time.
All right. Yeah. Let me see who else is on. Otherwise, I'll show you a couple. Okay. Okay, the first one is just a opportunity I had for a imaging and pathologic correlation. So let me bring in two CTs obtained this time apart, so December versus July of 2021, and I'll make these coronals to show you the small lesion. I just want to see if I can do that. A very small lesion in the peripheral right upper lobe there versus here. Now, what can one say about that other than it's very small? Let me make this one slightly thicker. Because I had difficulty telling for sure whether this had actually increased in size over time. So let me make this one bigger. It's clearly just a very small, ill-defined, one might call it part solid lesion. In a case like this, because it's quite small, we know that some of this is pulmonary vessel. I couldn't tell for sure, but I wondered whether a small component of this had changed over time. In other words, the solid component here was something that had changed, but I wasn't really sure. But I came across this after this was removed, and apparently a CT-guided biopsy had shown that this was adenocarcinoma, or it showed tumor cells. So as you might expect, they didn't do a lobectomy for this, but just did a localized resection. So I asked my pathology colleague to send me some images of it so that we can look to see what this looks like kind of under the microscope. So it turns out, and I'll make this big, that most of this is just collagen. Most of this is just fibrous tissue. So here, you can see the comments here. Not sure the scarring corresponds with the lesion on imaging. It was in multiple sections throughout the sample. So that's just collagen. And then I will show you here that there are findings of tumor cells. And this is a nice demonstration, particularly on this more magnified images, of in the midst of all that collagen, we have tumor cells growing along interalveolar septa. So this is entirely in situ lipidic growth of adenocarcinoma along these interalveolar septa. I asked her whether there were any findings of microinvasion or stromal invasion. She said no, this is all in situ and just these tumor cells in the midst of all this background, I don't know why, collagen that's also present here. But of course, these blue cells here are the adenocarcinoma cells growing along interalveolar septa. So kind of an interesting radiologic pathologic correlation for this small lesion that was removed. And perhaps not easy to tell, there was some growth of some component of it between July of last year and now, but I wasn't really sure about that. Here is another lesion. The saga here started off with the discovery of it on MRI, abdominal MRI, unexpected finding. Here is the lesion. A workup followed. This gives you a feel for it here. And I'll just go to right down here to give you a feel for its size. And then alongside it, I will put up the DOTA-TATE scan, which is here. So yes, indeed, upon removal, and I don't know for sure, I can't remember for sure whether there was a preoperative diagnosis by means of a biopsy of some kind. But on removal, it did turn out to be a typical carcinoid tumor. Now, what's really intriguing about this in part is that, and it turned out to be the case at surgery, this was primarily in the right middle lobe, but the lesion had actually grown through, even though it's a benign, typical carcinoid, into the anterior portion of right lower lobe here by a bit. So they did a right middle lobectomy, and they did a so-called wedge resection of a portion of the anterior right lower lobe here to get it out. And I thought that was curious, that a relatively benign actor would actually traverse the fissure. Now, it's also possible that maybe the fissure here was incomplete. It doesn't particularly look incomplete, but maybe it is not entirely complete. And it's not literally traversing the fissure, but they did have to remove a portion of the anterior right lower lobe to get this carcinoid out. But otherwise, a nice DOTA-TATE scan for a carcinoid. This is potentially a challenging radiograph. So if you don't really have any history and you're faced with a bedside radiograph like this, and let's say this is the default mode, and I'll just mag this up a little bit, you would be really hard pressed to see anything at all. But if you're told the patient has a lot of chest and upper abdominal pain, and you say, let me look more carefully, and this is what I always teach my residents, that when you're looking at an image, your finger should be on the mouse so that you'll be looking through the heart, changing the window display settings. And if you do that and you begin to look there, then you're beginning to see, oh, maybe there's something wrong here, in particular, gas there, that ordinarily would easily escape detection. Now, this patient turned out to be quite ill, so that some additional imaging followed, of course, but it's really just a nice example of how you can not perceive substantial abnormality in the mediastinum unless you're really looking hard and appropriately changing your window level and your window center. And you'll see here that this turns out to be a substantial amount of abnormality. This is Boerhaave syndrome. Here you can see how much abnormality is present in that basal chest. Not only is there abnormal mediastinal air there, but it really traverses the esophageal hiatus to involve the upper abdomen. And you can see how much abnormality there is in this patient with Boerhaave's syndrome right there. So kind of a cautionary tale, but certainly this would not have gone undetected because this patient was very ill. Okay, let me go on and show you an additional case. So let me just try and make that go away. Don't know what that is. Okay, so this is a patient that has an image in October 2022, and here at that time she has an esophageal stent. Other than the fact that she has an esophageal stent at that time, it looks all right. Let's go forward in time to when she is quite symptomatic. At this time, you can see there is an esophageal stent, but there is extensive pulmonary abnormalities, particularly on the right side, right upper lobe, right lower lung, to a lesser extent on the left side. CT done at that time shows the nature and extent of the pulmonary abnormalities. Multilobar, multifocal, lobular consolidative opacities are present. A lot of the opacities are airway centric. If I scroll right down here, you can see that there is a lot of abnormality involving the central bronchial tree, like the right lower lobe, a lot of abnormality in the right middle lobe. Yes, there are also pleural effusions, but substantially asymmetric opacity, which in a patient with an esophageal stent certainly suggests the possibility of a problem, a complication, and a bronchopulmonary aspiration. And I'm sure those of you that were looking as I scroll down really fast recognized the problem, which is unfortunately the spontaneous erosion of the superior portion of the stent into the airway right here. So there is at the superior margin of the stent a fistula between the stent that has eroded into the left main bronchus and airway. That, of course, is the source of the bronchopulmonary aspiration, but that's the fistula. So I'll just bring up some of the clinical note here. And here you can see some of the context that she's had a refractory esophageal stricture. She had a stent placed in. This is the EGD at the time, confirming that there is the fistula right here formed between the stent and the airway. They tried to close it primarily using some of the endoscopy system that they sometimes, but that didn't really work. So they had to go in and put another stent to cover the opening. So just an unfortunate occurrence in a patient with an esophageal stent placed for a benign lesion, esophageal stenosis. I don't know what the etiology is, but complicated by fistula formation. And then, of course, associated aspiration of esophageal contents into the right lung in particular, rather dramatically. All right. This one is no mystery, but I'll just show it anyway. Patient coming in with symptoms. If you don't have any history, you might go right by this. And I'll just cone in right to the offending agent right here, which is this. And just exactly as it looks is an aspirated nail. Here's the blunt end. There's the sharper end of the nail into the bronchial tree. Of course, with that, if there's an associated opacity in the lung, one would think of bleeding, occlusion of airways by blood perhaps, resulting in that finding. CT, no surprise, you'll see that here is the nail, and here is a lot of material accumulating in those airways and dilating them, presumably bleeding from that nail. And that was successfully removed via bronchoscope, uneventfully so. So I don't know what happened, but the patient aspirated in some context, maybe doing housework or something, a nail into the airway right there. No mystery about the case and a nice outcome for that patient. Here's a more mundane case, but this is particularly for trainees. So I was looking at this case with one of my residents, and I'll put up this one to compare with this one. So the time between these two images is the 16th versus the 27th. And in discussing this with one of my trainees, the trainee correctly identified the presence of new pleural fluid. And we said, yes, there is new pleural fluid in the hemithoraces. But then I said, okay, can you see a potential explanation for the presence of new pleural fluid? Because otherwise the chest radiograph looks fine. The heart's normal in size. The pulmonary vessels this time are normal in caliber. But in my experience, people forget to look outside of the ribs. And this right here is the clue as to the etiology of this. So we have pleural effusions, but also very substantial soft tissue, extravascular, extracellular water. So people use the term fluid overload or fluid overload in different ways. One way would be to say it's a traditional nephrologist way to think about fluid overload, where they talk about total body water. The patient weighs more today than some days before, and they implicate extravascular, extracellular body water. The other way, depending on the context, that I talk about fluid overload is in relationship to hypervolemia, where there's an expansion of blood volume. And usually I teach that one should look at the azygous vein, the vascular pedicle, and look at the pulmonary blood vessels to diagnose hypervolemia. But this patient has massive extravascular, extracellular water, not hypervolemia per se. But a nice, sufficient explanation for the effusions in a patient like this is fluid overload, in the sense of, yes, there's capillary hypertension. That's where the fluid comes from in the pleural space. But if you see this massive amount of soft tissue edema, you can put it together very nicely that way, as that form of fluid overload in part. So trainees, don't forget to look at the soft tissues. And particularly if you have a comparison, you'll be able to work out a case like that quite nicely. This is just a matter of picking up what's wrong with an image. So I'll put these two alongside each other. And you can take the frontal radiograph and you can change the window width, you can change the window level as much as you like, but you can't get it to look like a normal, conventional frontal projection of the chest. And you can see I'm changing the window width quite a bit. And the window level, make it look like this. And the clue is, if you look up here, this is labeled thorax lateral, this one thorax lateral. So this is an example of when you tell the digital radiography unit to use the wrong body part to reconstruct an image, it will apply its algorithm, its reconstruction algorithm here for a lateral projection to a chest radiograph, and it will not result in a satisfactory image. So this is simply telling the DR system and putting in lateral thorax instead of frontal thorax. So this is just a matter of recognizing the technical nature of that problem like that. This is a nice case for our trainees, blunt chest trauma. There are many findings of chest trauma here. You can see the usual combination of tubes and catheters in a trauma patient, ET tube, left chest tube. One very revealing finding is the fact that this gastric tube curls up superiorly. That, together with substantial pulmonary pleural space abnormality, should make one think of traumatic rupture of the left hemidiaphragm, which is indeed the case. Here I'll show you, and I always tell my trainees that the images you want to look at that make it really easy to confirm that diagnosis quite quickly is to look at the coronal and sagittal reconstructions of the chest. So if you do that, let's see if I get this in the right order, you'll easily be able to see the extent of injury and how large this injury actually is. So here you can see that this is a very large tear of that hemidiaphragm. What's really interesting is so much of that diaphragm is torn that the residual muscle has retracted substantially on both sides of this large defect. So this muscle here is thick, and this muscle is thick, and the defect is huge. So there's a substantial traction abnormality. So a very large defect was present. They operated on this patient, and here is the post-op imaging. And what we saw here, and I'm not sure we would have picked this up without reading the op report, is that post-operatively, there still seems to be a portion of the stomach in the lower chest, not nearly as much as before. But here is spleen, here is hemidiaphragm, and this looks like the stomach. And indeed, based on the op notes, this was such a large defect that they were unable to completely repair it primarily, and they left an unrepaired portion, the one portion they couldn't fix entirely. So they knew there was a residual defect involving this portion of that left hemidiaphragm, and perhaps they'll try to fix that at a later time, but I'm not really sure. So unavoidably incomplete repair of a very large traumatic rupture of left hemidiaphragm with still some remaining defect here. A little bit hard to tell exactly what's going on, but this turns out to be stomach. And the op report fit that observation very nicely, actually. All right, I think I have shown pretty much everything. The previous were from last week. So I showed you a whole bunch of cases. All right, I think we're done. Seth, do you want to show one more if you found that case? Or are we done for the week?
I could show it real quick it'd take
Okay.
2 seconds.
Let me go back over to you if I can figure out how to fix that again. And try to, that's really weird. Let me just give me a moment here to try and, I can't see these things. They're too small. That's crazy. Hold on.
And if you can't do it, it's not the end of the world.
For some reason, it's projecting so small. Even with my glasses on, I can't even see what I'm doing here. That's weird. Let me just see if I can find you. Let me try something else, but I'm not sure what else. Just give me a second. This is odd. How come that's happening?
It's fine. I can save it for another.
Okay. maybe I
time.
can't tell
It
why
was
everything has
not
gotten so small. I can't read anything.
yeah, no worries. Not the most
Okay.
interesting case anyways. All right.
All right, everyone. Thanks. Thanks, everyone. Thanks for those cases. Same time next week. Bye, everyone.